Good morning, Dr. John Rothwell. We are live on Facebook.
Live again?
Live again. Here we are again.
Well, good morning, Miss Jannis from Clarity Based Marketing, focusing on your promotion. And we're going to talk outside the box 2021 now. Crazy.
Yeah,
Crazy.
I threw a little slash in there for the 2020. So, like 2020 vision.
Outside the box, seeing it 2020. And look, what a great way to view through my lens, right? Because for me, I was talking about meeting people where they're at. And so today's world, right, with everything that's going on with the pandemic, you have vaxxers, anti-vaxxers, selective vaxxers. Blah. It's almost like 10, 10, and 10 versus 2020. I mean, it's nuts to just be able to sit here and communicate with everybody where they're at. And so I like that, 20. You got to be able to see both ways, right? And so, or you can just be a meathead and not be that way and make your patients mad, but that's not me. So
how you doing? Thank you. Thank you. I'm having a good day.
Awesome.
It's a good day. So today I pulled a little rabbit out of the hat on our subject. So our subject is, and I'm probably going to say this wrong, monoclonal. Monoclonal? Is that how you say it?
Monoclonal antibodies, yeah.
Yeah, monoclonal antibodies. So COVID is hitting home for me right now. I have some family members that are battling it, and I have one family member in particular who's really struggling with it, and I'm praying for good outcomes for him. And so I was thinking about this monoclonal antibody treatment this morning. I thought, well, we'll just talk about it because I have some questions. We always tend to do that. We talk about the things that Jannis has questions about.
Sure. Makes it easy.
So there are a lot of questions about that. I noticed a few weeks ago, I guess there's a place not too far from where I live that you can get the monoclonal antibody treatment, and they've got a big sign out there, and it says, monoclonal treatment here. And I don't know much about it. So what is it? Who should get it? Why should you get it? Shouldn't you get it? What does it do? What, all the stuff. So all the questions. And if you're watching and you have a question about monoclonal antibody, jump in. You can comment. I can see your comments live, and we'll answer them. So floor is yours, sir. Dr. John Rothwell, DNP, APRN, FNP-BC. See, I see it. It's on the screen right there. Great. I love it.
Yeah. So monoclonal antibodies.
What does it do? What does it do?
Well, remember the word cloning. I think, when we get into, like back in the day, Star Trek and all those sci-fi type stuff back when we were growing up, cloning was just pie in the sky.
Yeah.
And then within the past 20 years, what they do, clone a sheep.
Yeah.
Right. So monoclonal, so it's single cloning of an antibody. So it's a white blood cell. They're cloning a white blood cell.
Okay.
So that your body thinks it's one thing, and so you're providing a clone, so that your body thinks it's, in this case, would be COVID, and would start making antibodies for it, in a nutshell. So it's not a vaccine, but it's a monoclonal antibody. So vaccine causes your body to make antibodies to fight the actual disease. Monoclonal antibodies, you're actually making the antibodies.
Okay.
So that you can fight the disease.
Okay. So let's say you have COVID, and so monoclonal antibody treatment is an option for who? Who's an option for?
So the literature that I've read, it's for people who've been sick for less than 10 days.
Okay, so that's the first thing. People who have been sick for less than 10 days. Okay.
Yeah, and for me, I'm a little bit more conservative than that. I got to narrow our gap. I want to, less than 6 or 7.
Why is that?
So if you're trying to be foundational here, the report that I read revealed that if you give monoclonal antibodies too late in someone who is sick, in other words, someone who has lots of the virus replicated, that you could actually make it worse.
Okay.
And so people tend to actually do worse versus doing better.
Okay, that makes sense.
You won't necessarily get in the late stage of the game, like someone who stays at home for a week and then they deteriorate and they go to the ER and then they get admitted to the hospital. The Regeneron is not, may not be the best option for them. They might have other options, right? And so it's kind of like thinking of it this way. Dr. Williams has talked about this from MedFast because he posted this on social media, so I'm okay with talking about it. He didn't know he had COVID. We gave him the COVID vaccine. The day after we gave him the COVID vaccine, he tested positive for COVID. So he was wicked sick.
Yeah.
Wicked sick, right? So if you think about it, now you have COVID and it's replicated a bunch, right? And now you give these monoclonal antibodies, and so you're just double dosing the body when the body's already at a weak point. So
monoclonal antibody is the same concept. It would, no, maybe
not the same, because one's a vaccine, right? You're doing the vaccine and you're doing it in messenger RNA with the nanolipid protein, so just a protein. Coronavirus is a spiked protein, and so that's what you're doing with Pfizer and Moderna. And then if Johnson & Johnson, they're doing the adenovirus as the carrier of the spiked protein. So you're introducing the spiked protein in the body. The body looks at it as a foreign body and builds antibodies to fight it. In this particular case, we're cutting off that middleman and we're putting in an antibody that we've cloned.
Okay.
Cloning antibodies, I think, that's early mid-70s type technology. So they've been doing, these kind of things for a long time. But just remember, the most important thing here is none of this stuff is FDA approved yet.
Well, the monoclonal antibody is FDA approved, right? I did a little bit of research before we talked, just because I saw it was approved in November of 2020. I wrote that down.
Is it emergency use authorized?
Oh, yeah. Okay. Maybe. That may be the case.
That's the...
I can't speak to it. I closed the window on it. I shouldn't have. I should have left that window up so I could refer back to that, but I didn't.
Yeah. So they authorize it, but it's not authorized for pre-exposure prophylaxis to prevent COVID-19. So, so there's a lot of different things that surrounds the utilization of different technologies and or treatments for COVID, which makes sense, right? It's new.
Right.
And so,
sure.
And that's part of the fear. People are like, well, it hasn't gone through the same testing as everything else in the past, so I don't want to do it yet because, we haven't tried and true. And, why is everything emergency use authorized? Is that kind of like because we live in a litigious society and the government's protecting its ass, right? So
could be.
I said ass on live on Facebook.
You did. You're gonna get.
I've never been to Facebook jail. Never been to Facebook jail. So
now you're headed. You're going to the chain gang.
So we have all these different things and protective mechanisms in place, and nobody wants to make a decision. Right? It says we could do this for emergencies only.
Yeah. Don't sue me. Don't sue me. Yeah.
Emergency use authorized, and then someone has to determine what the emergency is, right? And so in some cases, it's the patient. So like in my case, we do joint decision making. So I have patients who have chosen with education to do a number of different things. And as long as it's safe, that's what we've done. In some cases, some people don't have a choice, right? So they might work in a specific environment, and that environment has dictated that this is the choice that you're going to, this is the choice that we've made for you. You know, and so down on the line. And look, if that's the case, then they own it, right? You got to own your decision.
All right, let me recap for a second. So you explained what monoclonal antibodies are. So if you're just watching us now, you'll have to go back and watch the beginning. And I kind of sort of understand, not 100%, but I kind of sort of understand what monoclonal antibody is in general. And you should, if you're going to get it, you should get it within the first 6 to 10 days, it sounds like. And
you have to, I mean, the people who are getting, so I've had 8 patients take the monoclonal antibodies.
That was my next question, is have you had any patients that have taken it, and what has been the result?
Okay. They've all been very different, not dramatically different, but been different. My patients who kind of follow my gut health protocol and my immune protocol and stuff like that, and that are fit, they tend to do very well. Like within 24 to 48 hours, they're, you know, they feel almost normal. They get a little tired quicker, but in general, they do great.
Okay.
My patients who are obese tend to do the worst.
Yeah.
As far as when I say do the work, they're not really doing the work, because I don't have any patients in the hospital. We've had over 30 patients. So I have over 300 patients now. And so we're pushing like 320, and 10% of my patients have had COVID, and none of them, no hospitalizations from that perspective. We had one in the early on, one patient. So, but we've been able to keep them out of the hospital. And so those patients who were obese, who, you know, they weren't vaccinated and they got the monoclonal antibodies, you know, we're looking at a 3 to 4, sometimes 5 days of still, man, they're not doing well. They just don't feel good. But that's most of it. You know, like you see pictures of me on social media going into people's homes and stuff like that. That's for various reasons. First and foremost, that's to let them know that they're loved and they're cared for, and that I'm watching over them. And I don't want them out of their house, first and foremost, right? If they were serious in emergent conditions, those are emergency folks. I'm an emergency medicine trained, also nurse practitioner in urgent care, and my board certifications in families. So when these things occur, you know, we're going the route that we need to. By staying up on it, like the monoclonal antibodies, and following it, I can go there, get O2 oxygen saturations and pulses, give them a sense of relief, you know, kind of reduce that fear, because people are sick. I mean, this is like worse than the flu. For some people, they felt like the flu. It felt flu-like, but people who have chronic illness, people who are obese, people who have unhealthy guts, people who have, you know, autoimmunity or low immunities, they don't do well and they're miserable. And so when I'm talking to them, their O2 saturation is like 98%, and they're calling me every 2 hours like they're dying, right? Because that's how they feel, you know. And so we got to kind of balance that out, because they're just, you know, they're just miserable. And then there's the healing process, right? Now you have coronavirus causes systemic inflammation. So it causes an inflammatory response in the whole body. It doesn't just go away overnight. Hi, 10 days, I'm infectious. After 10 days, I can go back to work, but I've had COVID and I can't work longer than 2, 3, 4 hours because I'm just exhausted. I can't eat anything. I'm bloated, you know, I'm swole up. And I'm like, look, your body's just been in a constant fight status, that fight or flight status. They've been in that constant fight status for the past 10 days or 14 days, however long it is for you. And so tough. Sorry, it gets me excited because, you know, I've been in it, and, you saw me on vacation last week in St. Thomas. It was a wonderful time. Got me a nice little tan. But I had patients who did have coronavirus, COVID-19 while I was gone. So I was still working. Thank God for NOLA, doctor nursing practice, registered nurse right now, but she takes boards next week. And so, we were able to manage through that. So we have one active COVID-19 patient right now. And
that's good. Only one. That's good. Makes things, better. All right, I have one more question about monoclonal antibodies. Just one more, and then we'll wrap this thing up. So when it first came out, when they first started, offering that treatment, you had to meet some criteria. It was like for high risk people only. And is that the case now, or is it just like whoever shows up and says, "Hey, I got COVID. Here's my positive test. Give me the treatment"? Or are there some prerequisites? Do you have to fit into certain categories?
We live in a very dishonest society, unfortunately.
That's not my question. My question is, are there?
I don't work there, so I can't speak for them. Let me tell you my experience.
Okay.
My experience is if I have a patient who has COVID-19 and they have a family that's with them, everybody's gone and been able to get the monoclonal antibodies.
Okay. So let me ask this. So let's say hypothetically, I am not seeing a doctor. I just go and I get the test and I test positive for COVID. I'm not talking to my doctor, which I would be, of course, but
after you Google it.
After I Google it, true that. Well, because I am a doctor, but anyway, so I am COVID positive, and there's a facility right down the road that has a big sign that's flashing every time I drive by that says, we do this here. Can I just go to that facility and say, "Hey, I'm positive and I want that treatment"? Are they going to say, "Okay, well, let's see if you're eligible for that treatment," or are they just going to give it?
They're going to ask you questions. You're going to check yes or no. You don't even have to take them a positive test, and they're not testing you.
That's okay. I'm not talking about that. That seems a little.
I'm just saying that's my experience, right?
Okay.
Right? But you know what? Look, again, this is society. Literally, I've sat here and watched on social media people because of the testing rules, right? So MedFast has been great in this whole pandemic. 13 facilities, hired 2-3 times as many people to help take care of people, and still with 60 people lined up at 6:30 in the morning to test. They're not a testing site, but if you're sick, they are an urgent care, right? And so people were like waiting 3 and 4 hours to get tested, even though they weren't sick. And so they had to put out a message saying, "Look, we're only taking care of symptomatic patients. If you need to go back to school or go back to work, go to a testing site." Because remember, the CARES Act is paying for this, or the insurance company is paying for this. There's no copays or no deductibles. And so I literally watched threads on social media with people telling each other well, just tell them this.
Sure.
And they'll test you.
Sure.
They weren't telling the truth. And I sat and watched literally a young 20-something-year-old female who was sick, who needed to get tested so it was determined if she, what the challenges was, waited for 3.5 hours while umpteen dozen people who had no symptoms at all, no sickness or whatever, came in and got tested. And she was sick. And that's sad. So that we're taking we're that selfish.
Yeah.
And I get it. Look, nobody wants to be sick. Everybody's overwhelmed with fear. Everybody deserves to be heard. It's one reason why we got this going on. And so as a medical community, we need to let our guard down a little bit and not be afraid to talk so openly about everything that's going on. We don't have to own it. Look, I said, I'm not the monoclonal site, right? Kiwanis Park, they do it, right? How they manage their business and how they're managing the process is them. But what I can do is share my experience, right? And so, and you go through that part. But if you have symptoms, look, sore throat has been a symptom for COVID. People have had a sore throat and tested positive for COVID in my office. I've sat in my office with people without mask on, and then they tell me, I did have a scratchy throat. And I'm like, daggone it, why didn't you tell me? Where's my mask? And I test them, and they're both husband and wife, and they test positive for COVID. And I'm like, they've been in my office, 1 hour at a time, right? One patient per hour. And I'm like, oh boy. So, 4 days later, I'm testing,
Yeah, for sure. So would you recommend, last question, this is really the last question. I think I already said last question twice, but this is really the last question. Last question. Would you recommend that somebody go get the monoclonal antibody if they test positive for COVID? Because, when you first test positive, you're not all that sick. And, I've seen it in people that I know that have gotten sick. They tested positive and they didn't get super sick and for, 5-7 days. And it sounds like you don't want to wait. So if you get a positive test, should you just go get that treatment and be done with it? Yes? No?
I think that you should have a relationship close enough with your healthcare provider. I'm not trying to be copping out this kind of a bullshit answer.
Okay. I think, oh my gosh, did you just cuss again? That's the second time.
This stuff makes me feisty. It makes me feisty. And I'm excited. I'm going to a mastermind conference this weekend, so I'm leaving this afternoon. Look, my patients, I review ivermectin with them. I review monoclonal antibodies. We have our we have our immune protocol, supplementation, stuff like that. And jointly, we discuss all those options and jointly we make a decision. And so what I'm saying for me is I've had patients do all of them. Okay. Ivermectin, monoclonal, and all that. And I've seen success with all of them. Okay. Because of a patient-provider relationship and in the society we live in, I'm going to err on the side of caution and just go, look, here's the most important thing. Talk to your healthcare provider about all the options that are out there and make a joint decision, right? Not a judgmental decision.
I hear you, but I have to stop you and say that there are a lot of people out there that do not have a relationship with a healthcare provider, and a lot of people. But I hear you, and I agree, right? I do. I agree with that. But for somebody, and I know you can't really make a recommendation to somebody blanket like an unknown person, but there are a lot of people out there that get a positive test and are just like, now what do I do? And, I don't know. Like I said, I have family members that got positive and they're past it now, that's not even an option for them now. But I have
great success with my patients in monoclonal antibodies.
Okay.
And some people would argue the problem is the fear of the unknown. They don't know what the long-term ramifications are for the vaccine.
Have there been anybody do you know of any cases where it was a bad thing to get that?
Like I already said, if your timing is not right, then there's reports or literature that says that it can make some things worse. And so that's tough. It's just like there's no one set protocol for this. It's like dexamethasone I've been giving for patients with COVID since way back when, and they were only doing it in the ICU and IVs. And I don't do it right off the bat, and because there's a lot of things that steroids do to the body and the body's immune system, but we also do it for inflammation. And so you really need to, you're timing it with the patient's disease and the symptoms and what's going on and what you can tell, so that you're not giving antibiotics when they just have a virus, but you give antibiotics and everything's fine, and then because you gave a Z-Pack and it's 5 days, on day 10 they're in the hospital with COVID pneumonia or a viral pneumonia that now become bacterial pneumonia. And so I'll watch all that. And if I think so, I'll do a chest x-ray and have them come in. I'm like, you know what? And then we'll get them on antibiotics, to be more aggressive, and maybe something different, an old school antibiotic like doxycycline, and do it for 14 days. So we have this long window of coverage. That's kind of the art of knowing your patient, knowing what's available, and doing what's out there. So,
well, I appreciate your time always, and your expertise and weighing in on this. This is really something that I didn't know anything about. I want to mention that Sheree Smith weighed in. She commented and said she was going to listen from the beginning. So I hope that it's helpful, Sheree. Thanks for being here. And thanks for always sharing your information with me. I appreciate it. I've learned a lot about it. And I think if I got COVID, I think I would just go get that. I don't know. You would tell me what to do.
I know what you would do.
You know what I would do?
The first thing you do is Google it.
Yeah, you're right.
And then you would call me and see what my recommendation would be.
Yeah. Well, no, then I would call you and I would say, hey, this is what I think I should do. What do you think?
Yep. And look,
yeah.
I think that's okay, right? And so it's taking the action before the discussion is always challenging for the provider. But having patients who are just trying to educate themselves, it's okay. If you're going to educate yourself, scholar.google.com is a much better resource than google.com. And so this is where scientific literature lies. You can actually set dates, like anything newer than, from 220 for 2020 on, or 2019 on. You can set those parameters and just type in COVID-19 and all these cool things up. Obviously, most of them are observational studies. They're not peer-reviewed studies. There may be some, just, you have to pull that stuff out of the information.
That's good advice. Scholar.google.com. I've never even heard of that. So
sure. And so, like, if someone says, look, is vitamin D really worth it? Or, what does vitamin D do?
Scholar.google.com.
Yeah.
So no www, just scholar.google.com. I like it.
Scholar.google. And this is what I do with my students. And so, as faculty at University of Central Florida, I have access to the library and those kind of things. But oftentimes, I don't want to log in. And so I'll go to scholar.google. And then if I need the articles, because not all the articles are free, but many of them are. But if they're not, then I can then go to a different source and, get access to them through the library. So now the most recent thing is kind of looking at the Mu and Lambda variants with COVID-19, and also some other things that are coming up from Asia and Japan on some of their research that they're doing. Unfortunately, COVID does not run my life or my practice. We do, we keep up with as much as we can. I'm no longer reading it every single day. Most days I'll glean it. So the more fresh your questions get with new things that come out, I might not be as first, because look, common illnesses are still common, and there's still plenty of people who have issues with gut health and autoimmunity and those kind of things. And if I can help people in those environments get healthy, then they're better positioned to combat viruses like SARS-CoV-2 or COVID-19.
You know what I think would be a good thing for us to talk about? Not today, but maybe the next time, is how to use the internet responsibly to Google what's going on. Because scholar.google.com, I wasn't even familiar with that. And you're right. And I think maybe most of us Google, we shouldn't, but we Google. And we find all these things, we're dying from.
It's an action word.
Yeah. So let's do that. Let's have we'll talk one day about the best way, if you're going to Google, the best way to do it most responsibly. So thank you again, as always. If you're just joining us, go back and listen. We got some good information on monoclonal antibody treatment. And I'm going to let you get back to work, sir.
I'm heading to the airport.
Oh, okay. Well, head to the airport then. I have to get back to work. So
I'm going
have
to
a
work
great
through the
day.
weekend, so I'll be there. But that's nothing new here. So we'll talk to you later.
Thank you. And if you joined us, thank you. Oh, Candy says, welcome back from your vacay. And
Oh yeah, she watched me and my foodiness, so that was for sure.
yeah. So I'll see you next week.
See me next week. You know,
Right here, same
we're
time, same place.
yep, same time, same bat channel. We're doing what is the day next week?
I have no idea. I don't know what day
Okay,
it is today.
yeah, cool.
Okay.
We'll do it.
Sounds good. Have a good one. Bye, everybody.